Good, found it. Okay, thank you very much. Good morning. I should point out that I am, as of today, the former National Clinical Director, so my post ended yesterday, so my status update today is unemployed or retired. So, and I'm sure there are people who have ideas of what I'm going to do with my time. I know Fede thinks that I'm going to run some sort of import agency across the channel, bringing English products such as fish and chips and piccalilli. And if anybody doesn't know what piccalilli is, I'll talk to you later and explain it. So thank you. It's been really good to be here, and this tremendous success, this Congress. I was looking at numbers online, 2009 yesterday. I'm sure that's probably about 4 or 5 times the number of people we have had at congresses in Berlin, in Barcelona, and other places. So thank you. And I've hopped further up the schedule because I need to be getting to the airport fairly quickly. I've got a fast horse waiting for me, because anybody who watches United Kingdom probably thinks that news probably thinks we all ride about on horses, which of course we do. So we'll be going at 1 o'clock. So thank you. I wanted to talk to you about the National Autism Strategy and the Autism Programme in NHS England. So let me check how I get the next slide. How do I do this? Do I click on this one? Yeah, okay. So let's put this in context. In the United Kingdom in 2009, there was an Act of Parliament passed called the Autism Act, and that placed a duty on governments to meet the needs of autistic adults in England. I should change the language now from what I've learnt yesterday. I should be saying should meet the requirements of autistic adults in England. And by preparing and publishing an autism strategy for improvement in delivery of services to autistic adults from local authorities or social services and the National Health Service. And this strategy would be reviewed every 5 years. So it's currently actually under review again. How am I operating? Whoops. It's not a good way. Okay, thank you. Thanks. The other impact of the Autism Act was to place a duty on government to produce statutory guidance for local authorities, listing 7 points to be included in what they called Fulfilling and Rewarding Lives guidance. So, guidance for diagnosis of autistic adults, identification, providing assessment of needs, transition between child and adult services, provision of other services to autistic adults, training on autism for staff providing the services, and local arrangements for leadership in relation to the provision of services. You notice, say, adults, and this is because there's legislation for children under the Children Act that would cover many of these aspects. Within NHS England, I shan't try and explain how NHS England works. It's incredibly complicated and has just changed yet again. But NHS England sits as an overall kind of commissioning body for health services in England. England particularly, Wales has its own arrangements, and Scotland has its arrangements, and Northern Ireland has its arrangements. So this is England. We have, and have had for the last around about 7 to 8 years, a national programme for learning disability, and then more recently learning disability and autism. And the main focus of that programme is improving quality of care in hospital settings, reducing the number of people in hospital, improving provision of community services, outcomes for children and young people, outcomes for autistic people, improving health outcomes and access to healthcare, and importantly, building a capable workforce to deliver that. What we know nationally, and why we have a programme for autism in NHS England, is so there are probably around 1 million autistic people in the UK. Around 20 to 30% of those also have an intellectual disability, and about half of autistic people have a mental health condition at some point in their lifetime. Research shows that autistic people die possibly about 16 years younger than the general population. And 2023 is the first year that our national programme for looking at the lives and deaths of people with intellectual disabilities will now include autistic people. So every death of a person with an intellectual disability, and hopefully now, if we can get the systems to work properly, an autistic person, is reported to the LEADER programme, which will then look at the circumstances of that death, investigate it further, and try to understand what things should have been done better to meet that person's needs and to avoid early death. We know that around 143,000 children, young people, have autism stated as their primary type of need in education, health and care plans. That sounds similar to the plans that you were describing yesterday in Greece and when we went to the school about how plans are drawn up for children's education. But in England, they're expected to have these plans that include education and health and care. We also know there are more autistic people who don't have an intellectual disability in mental health inpatient services than ever before. We had 755 children, young people and adults in October 2022 compared to 580 in March 2017. And in the what we call the Assuring Transformation Group, so those where we have oversight of people who have been admitted into specialist mental health hospitals, we know that 80% of the children in children's hospital settings have a diagnosis of autism and no intellectual disability. And those numbers are increasing and have increased over the course of the pandemic. And the proportions have changed. So we have been able to move more people with intellectual disability out of hospitals, but the relative numbers and the real numbers of people with autism have increased. So the NHS has a kind of long-term plan and a number of commitments that are related to intellectual disability and autism. So there's a commitment to improving autism assessment pathways, including lengths of time that people are waiting. And waiting times are a big concern. They're a big political issue. They're a big public issue of public concern. We're committed to reducing the number of people in mental health hospitals, improving physical health and experience of care, and encouraging services to make reasonable adjustments. Reasonable adjustments is a phrase that comes in the Equality Act in the UK. It says that people with a disability, people with a protected characteristic under the Equality Act, services are obliged to make reasonable adjustments to ensure that they have fairness of access. And there's a commitment not just to ensuring people get the right high quality care when they use mental health services, but also to increase employment opportunities within NHS England and also elsewhere. And I made reference yesterday that we have some employed colleagues who have lived experience of autism or intellectual disability who work with us in our programme, but also elsewhere across NHS England. What are the key challenges, particularly in the autism assessment pathways? Well, the demand has grown exponentially across all ages without a corresponding growth in services. So we've seen a 40% increase in the number of people waiting for an assessment. Delivering improved pathways and reducing those times requires a very significant investment in a specialist autism workforce, people who know what autism is and know how to assess it and understand it. And that will require several years to actually grow that workforce and employ people and train them. There is huge variation between local areas in terms of services provided, the provider market in those areas, the way in which pathways are delivered, and in clinical practice. Considerable evidence of disjointed services in different areas, gaps in funding that are required to be invested in services for children and adults to meet that capacity and demand. We just switch this off. Tell my wife that I'm speaking. Sorry. And challenges with data collection. So how do we know what we're doing? How can we measure it? Where do we collect that data? And how can we look at that both locally and nationally? So the programme actually has three main work streams. I won't go through these all in detail. I'm hoping you will have these slides and you can read them at your leisure. So we have three main work streams. One is about improving access to and quality of diagnosis, including pre- and post-assessment support. The second work stream is about reducing the health inequalities that I talked about. How do we identify people's health needs? In England for some time, we have promoted annual health checks for people with intellectual disabilities. So an annual health check via their general practitioner, their primary care doctor. And we are looking to extend that to autistic people. Challenges, of course, how do you identify autistic people at a primary care level? How do we help people know who is on their list, who has autism, and who would be eligible for a health check? I talked about improving the LEADER, the oversight of premature deaths. Workstream 3 is about improving the quality of mental health treatment and support for autistic people. If there are so many people being admitted to mental health settings, are those settings actually able to work with the requirements of autistic people? Are those environments conducive to recovery and good mental health? And generally speaking, no, they're not good environments. But we have done work with the colleagues, National Development Team and others, to describe what autistic-friendly environments look like. How can you modify the environment in terms of lighting and space and noise, which is part of it. Obviously, the other side is what are the workforce skills that are needed to be able to support people. So we have produced that. Now, of course, I think if you improve the environment for autistic people, you generally improve it for everybody. I'm sure the kind of things that would make it more acceptable to an autistic person would actually make it more acceptable and calming and a better place to recover for anybody who's experiencing some mental health issue or distress. So a number of things. What is being done to address the challenges? We spend a lot of time, and people spend a lot of time telling us what the challenges are and saying, and what are you doing about it? So there are four. If we divide it into the four main areas, and again, I won't go into them in detail, it's just giving you the oversight, really. Part of it is supporting strategic cross-government policy development and action. So we work very closely with the Department of Health and Social Care, Department of Education, something called the Building the Right Support Delivery National Board, etc. So working very hard to bring lots of different agencies together to try and provide a coherent and comprehensive response. Partnership to support delivery. It would be pointless, NHS England, trying to deliver all this itself. How do we actually work collaboratively, co-productively with others to support these priorities with other statutory agencies, voluntary agencies, National Autistic Society, self-advocacy organisations, and how do we also support improving data quality, completeness and transparency. So we have produced a health informatics strategy to look at how we improve that, and again, hopefully there would be a link that you would be able to follow. As well as supporting government policy, we have been supporting strategic planning policy and project development across the NHS. Slightly complicated because over the last year, the NHS has changed shape yet again. I've lost count of how many times the NHS has changed shape since I started working in it. But we have moved to what are called integrated care systems across the country, about 43 or something like that. Supposed to be integrated care between health, social care and others, and then there are integrated care boards within that will look at the health requirements in the area, changing the kind of role of NHS England, of course, because there's a greater devolved responsibility now for establishing priorities and meeting them, which raises the question of how do you maintain this oversight and direction and quality and focus. But that's a headache that I can now leave other people to carry on thinking about, thank goodness. It means I can sleep at night, hopefully. And we talked about workforce, so supporting the growth and retention of a skilled and capable workforce, really important. And how do we build research and evidence? So one of the things that we did was to publish an autism research strategy to underpin the work of the programme. And again, that's something that's available and you can see. And we also worked with national research bodies on their demand signalling programme and demand signalling report about what should be the research priorities for people with intellectual disability and autistic people and their families. And again, links for you to be able to see those. In terms specifically of the autism assessment, an autism assessment framework, it seemed a very important point that, there is huge demand, an increasing demand, but let's not get carried away with trying to rush in and meet that demand without being clear about what should you be doing, what's best practice, what's the evidence-based practice for how you should make that assessment. So we spent lots of time gathering information from task and finish groups and meetings with people and families with lived experience and clinics and research organisations and et cetera, to identify what were the barriers and how do you develop guidance for local systems to improve. And in order to do that, we have been drafting an all-age operational model for clinical services and those in commissioning roles, and developing commissioning guidance for those people who are going to be commissioning services, and developing the workforce model. And the output of that is this all-age autism assessment framework. And within that, and this might be, if you were going to take one slide away, you might take this one. This is the kind of model of how the assessment pathway should work. So you will see, without getting into too great a detail, I think I've emphasised, we are clear that the assessment of autism and reaching a diagnosis is not simply about which diagnostic tool you use and how long it takes you to actually produce the diagnosis. Pre-assessment and post-assessment are really important. I say that also from the standpoint of having previously led the autism diagnostic network in Wales, which was produced on the back of a Welsh autism strategy, which there was clear investment in that strategy in pre-diagnostic counselling diagnostic services, and post-diagnostic support. All those things were emphasised. There is nothing worse, I think, surely, as being a clinician, sitting in a clinic or somewhere saying to somebody, okay, you have a diagnosis of autism, bye-bye, I don't need to see you. Where do you go with that? What do you do with that diagnosis? Who then also follows that up? What also, if the person that's been referred to, you come to the conclusion they don't have autism? Well, they had a problem that led to them being referred in the first place, so what are you going to do about that? So all these things are incorporated in here. So from the point of identification and referral, how do we make it easy for people in primary care, people in social care, etc., to be able to say, we think this person may have autism, or a parent saying, I think they have autism, or an individual themselves thinking, I may have autism. How can you then make it easy for them to access a diagnostic pathway? How do you support that? How do you have that screening and triage? And how do you have the discussion with the person about, so why would a diagnosis be important to you? Have you thought about what that might mean? What the impact might be? What do you think might change? What are you hoping would be better? Are there any disadvantages to that diagnosis? Have you thought about this? Are there other things that we need to understand? You may think you have autism, but what else is going on? Why now? Why have you decided now that this person or yourself needs an assessment? What else is going on in your life that means that this is the time? Because those things are also important to address. Having done that, then clearly you need the workforce and the place to be able to use standardised, evidence-based diagnostic tools, both for a straightforward diagnosis, but also when there is a complication, do you have, and it's not entirely clear, what enhanced tools do you have? And maybe how do you work jointly with other services in those assessments? So if somebody also has a mental health issue, if there are issues about attention deficit disorder, for example, how do you work together with others? And having done that, what further assessments might you need, up in 4B? And then, if you decide that the diagnosis is autism, what is the post-diagnostic support that you receive? And it's almost as if from the point of contact you have somebody holding someone's hand throughout that pathway, and you don't let go of that hand until you can hand them on to somebody else. You can put one hand into another at the end of it. Be that back to primary care, be that on to other services, services for mental health support, services for educational support, whatever. You need to be able to follow those through. And if the diagnosis is not autism, then what support do people need in working through that? So that's the overall model, and as I say, people have spent time working that through on the basis of evidence and consultation to make that clear. So looking to the future, what are we doing to support excellence in care and delivering on these commitments? So the programme will be keeping the focus and the attention on learning disability and autism at the national level, and people are tapping on their watches, and workforce capacity and skills, and the cross-agency and cross-government approach. These are all going to be the priorities for the national programme as it goes forward. Thank you very much.